Ma'am, we are starting, ma'am.
Yeah, sure.
Yeah. So, very good evening, doctors. I am Dr. Stalin here on behalf of Shield Healthcare, welcoming you all for today's webinar. So, the topic for today's webinar is all about an agonist trigger. I welcome all the participants and I request them to post their queries in the chat box so that we can have a short QA session at the end of this presentation. So, now it's time to introduce our invited speaker for the day, Dr. Krithika Devi, ma'am. Madam has completed her MBBS from Madras Medical College and MD-OG from GIPMER. Madam has her fellowship in andrology and reproductive medicine from Chettinad Hospital and Research Institute and undergone training program in reproductive medicine at Gleneagles Hospital, Singapore. Madam is currently the consultant at Nova IVF Fertility Chennai and currently the president of International Fertility Research Foundation, executive committee member IFS TN chapter, and author the chapter titled Frozen Embryo Transfer Protocols for Handbook of Ovarian Stimulation. So with the short introduction, I welcome you, ma'am, and I'm handing session to you, ma'am.
Thank you for your kind introduction. And first, I would like to extend my thanks for giving me this opportunity to be part of this academic program. And my next thanks for allowing me to choose a topic which I had always wanted to know more about. So, today we'll be discussing about agonist trigger. So, before we start anything, I always feel we should know the foundation from where we started. So, this is not a new drug. It has been in place right from 1971 when Scalia had first isolated it. So I'm not going to talk to you about a new drug. I'm going to talk to you about a drug which has been with us for decades. But we have found a new application to it or a recent application to it. So again, from the basics, whenever I say GnRH agonist trigger, I want each one of you to understand what do you mean by the term agonist. So basically, agonists are chemicals that binds to a receptor and makes a response for that cell. And it almost mimics a natural product. So this agonists are all straightforward people. They just go talk to the receptor and they just do their work. Now, if you look at the antagonist, they are molecules which biochemically resemble the natural product. But what they do is they go block the access or attachment of the molecule to the receptor and thereby prevents or stops the cell response to the natural agonist. So antagonists are blockers of a receptor, agonists are stimulator of a receptor. That's all. So now we look at how this GnRH analog is biochemically going to be. So they are mainly produced by the hypothalamus. So which part of the hypothalamus? The arcuate nucleus of the mediobasal hypothalamus. The interesting part of this molecule is their short half-life. In nature, you all know that GnRH comes in pulses and the half-life is just few minutes. So this is the molecule. It's basically a glycoprotein and it has 10 amino acids. And whenever we change this molecular formula, then we get the various products of agonist and antagonist. So this is again a graphic representation of how these molecules work at the receptor level. So a normal GnRH acts on the receptor and it causes the release of FSH and LH by the pituitary. So this is our GnRH agonist molecule, which again, after binding to the GnRH receptor in the hypothalamus, it causes a flare response of FSH and LH initially, but when you give the drug continuously, for example, like in a depot preparation, it causes a profound suppression of both these hormones by the pituitary. GnRH antagonists are hormones or drugs which goes and blocks the receptor and blocks the action of that particular molecule. So what happens is we have a lowering of FSH and LH immediately. So antagonist works immediately. Agonist initially causes a flare of FSH and LH, and if left in the receptor for a longer time can cause downregulation. So this is the molecular level working of all these drugs. Okay, having known what is an agonist and how does it work, let's see what are the various drugs that are available today with us. So in the GnRH agonist group, these are the various molecules that we have in hand. That is leuprolide, buzerlin, neferlin, histrulin, gozerlin, deslorelin, and triptorelin. And a lot of countries use a different molecule, but basically they are the same. And here nafrolin is given by nasal route, and the other drugs can be given either as a subcutaneous route or in the intramuscular. Okay, now let's see how these agonist triggers are different from the natural trigger response that happens in a physiological menstrual cycle. So let's start from the basics. You find that during ovulation, there is a peak of LH hormone, but the most interesting part is it's not just the LH that rises during ovulation, but it is the FSH also which has a peak along with the LH. So our GnRH molecules most specific or the differentiating factor from HCG is going to be this action where when you trigger with the GnRH molecule, GnRH agonist, we have both FSH and LH rise, which is similar to nature. But when you give HCG, which is a surrogate of LH, we have only this LH which is peaking. So this FSH rise doesn't happen with a HCG trigger, which we use commonly even today. So our GnRH agonist trigger works more physiologically. This is a difference. But look at the time duration of these two molecules. In nature, what happens once there is a LH surge, it lasts for a longer time. It has a plateau for 14 hours and then it comes down at 20 hours. So, roughly for about 2 days, you have LH action happening in a normal physiological menstrual cycle. Compared to that, when you give a GnRH agonist trigger, it is it attains a peak very quickly and then drops down also quickly. So the duration of action is almost half of what happens in a natural cycle. So as I told you before, the beauty of an agonist trigger is that it makes a release of FSH also along with LH. So why are we so interested in this FSH raise along with LH? Because in nature, when you have both FSH and LH raising during ovulation, there are some mechanisms which this FSH does to the oocyte and the cumulus complex. So, when you give only a HCG trigger, these are missing. And when you give an agonist trigger, we have these benefits of promotion of the formation of LH receptors in the granulosa cells. It promotes the oocyte nuclear maturation and cumulus expansion, and it helps in maintaining the gap junctions between the oocyte and cumulus cells, and thus may have an important role in signaling pathways. So basically, your FSH helps in giving you more mature oocytes and a better oocyte quality. Okay, so this is an basic advantage of an agonist trigger because it mimics physiology and it helps you in giving you a better oocyte. Now, the whole idea, the whole concept of GnRH agonist trigger was evolved for the sole purpose of beating OHSs, which is a very, very dreaded complication whenever you give a HCG trigger. So let's see how an agonist trigger helps in prevention of ovarian hyperstimulation. So that is something which no one wants to see. So why HCG invites OHSs or it increases the risk of OHSs would be whenever you have a lot of follicles. HCG has a slower plasma metabolic clearance. It gets out of the system much slower and it has a high serum concentration which can lead to sustained high level stimulation of your corpora lutea, which may lead to ovarian hyperstimulation syndrome. And the basic molecule that is responsible for this is your VEGF. So this vascular endothelial factor causes a leaking from the vessels and water or fluid goes into the third space. So for having a OHSS free clinic, it is first most essential thing is to use an antagonistic protocol. Remember, only when you give an antagonist protocol, your agonist trigger can act. So in an agonist protocol, long protocol, what happens is already you are giving a long acting agonist, so the entire HPO axis will be suppressed. So your agonist trigger cannot act. So for a OHSS free clinic, the most essential thing is to use antagonistic protocol by which you can give an agonist trigger, and then we can always freeze the embryos and then transfer later. So now the combo of ANTAC with the agonist trigger with the freeze all strategy is the most crucial factor which helps us in having a OHSS free clinic. So this is what I was telling you. What happens is whenever there is a HCG given to a hyperstimulated ovary, there is a lot of secretion of VEGF which acts on the blood vessel. It increases the vascular permeability and there is leaking of fluid into the third space, hemoconcentration because all the water goes out, so blood becomes hypercoagulable. There is hypovolemia, electrolyte imbalance, and this leads to the dreaded complication of ascites, pleural effusion, thromboembolism, and in the end, we can even land up with a metabolic syndrome. So, along with VEGF, the next culprit would be the renin angiotensin system, which works in hand along with VEGF. So, this is the basic physiology, what we don't want. And the main culprit is HCG. So, by replacing HCG with the agonist trigger, we help to prevent all this. So, let's compare how all the triggers that we use work. This is a natural LH surge. I told you it is long lasting. It has an ascending limb for 14 hours, a plateau of 14 hours, and then goes down slowly in 24 hours time. So in nature, an LH surge stays for almost 2 days. In comparison with that, GnRH agonist works for a shorter time, almost less than 24 hours, and it reaches its peaks quite fast. Now you look at the HCG molecule, how it works. It has got a long time, it's going to stay with you, almost a week after you give the HCG injection. So what happens? A prolonged action of HCG causes a rescue of your corpus luteum and maintains all your estrogen and progesterone in the body, and all these VEGF is going to work on the patient and land her up in trouble. So this is the basic concept of how an agonist and the HCG trigger works in comparison with the natural LH search. So as I told you, GnRH agonist is a very quick acting drug. So it just goes, acts, and then goes out of the system. What happens? It is a plus and a minus. So the plus is it reduces OHSS because the luteal phase for the patient is shortened. So she is not bombarded with high hormones in the body. The negative point is you don't have a good corpus luteal support. So what happens? You cannot transfer an embryo in a fresh transfer because the luteal phase is compromised. So as I told you, agonist trigger has got a effect on the luteal phase. It shortens the luteal phase and it reduces the ovarian volume and diminishes the risk of ascites. So this is about the trigger. Now let's just see how the luteal phase will be affected by a agonist trigger. So as I told you, the negative angle of an agonist trigger is that it causes a marked decrease in your ongoing clinical pregnancy rate and maybe an increased risk of miscarriage, mainly because there is a luteal phase insufficiency despite your standard supplementation with progesterone and estradiol. So this is a problem when you are considering a fresh transfer after giving a agonist trigger. If you are going to go for a freeze-all strategy, you are not even worried, and this is not even important. I'm talking about in a situation where you want to transfer with the agonist trigger. So how do we manage the negativity of agonist trigger, but still you want to do a fresh transfer? So there are actually two type of protocol. One is a European protocol, one is an American strategy. So European strategy is mainly where you add some amount of low dose of HCG in the luteal phase to support the corpus luteum. And in the American protocol, what they do is when you give an agonist trigger but still you want to transfer, they propose to give a higher amount of progesterones to support the luteal phase and they don't give HCG. So this is about the European protocol where after agonist triggering you want to transfer, you can add a minimal amount of HCG for luteal support either in the form of a single bolus of 1500 or repeated very minuscule doses of 250 or 500 of HCG in repetitive doses. So GnRH agonist ovulation trigger and HCG based progesterone free luteal support. It may be a future where you are giving an agonist trigger, but you support your luteal phase with just HCG alone. And remember, this is not for hyperresponders. I'm talking only about normal responders or low responders. So here you give agonist trigger and only HCG. You can give 1500 on the day of OPU, and after 4 days you can repeat another bolus of 1500. And this is a study where they said patient can be spared of the messy progesterones and they can just be with this all 4 days once HCG that is given. So these are modifications of the luteal phase whenever you want to transfer with the agonist trigger, because the main negative factor people are worried about giving agonist trigger is no, you can't transfer at all. So these are considerations where you can afford to transfer in a agonist triggered cycle. Now, this is one area where I've gone through a lot of literature and nothing is final. So it is like in my personal experience, I give that, and in my personal experience, I prefer that dose. So this is an average of overall dose that is being given throughout the world. Roughly commonly used dose I've mentioned here. So either we can give triptorelin 0.2 milligram or buzerlin 0.5 mg, or some people give leuprolide acetate 1 mg or 1.5 mg, or nafrolin 400 microgram. So most of these drugs are subcutaneous except nafrolin, which is given as a nasal spray. Now, there is another concept of giving a second dose of your agonist, probably at a lesser dose. See, for example, if you're going to give triptorelin 0.2 mg, say in the night as a trigger, suppose you're giving at night 10:30 the trigger of GnRH agonist, then the next day morning 10:30 you can give an additional dose or even lesser dose. You can give even 0.1 mg, 12 dose apart, and they find that this maintains a physiological levels of LH and FSH until the time of egg collection. Why? Why there are studies supporting the rationale of a second dose is because if you look at this, you find that after the trigger, you find both FSH and LH increasing in the case of an agonist trigger, but the peak value is attained after 10 to 12 hours. But during the time of pickup, there is a fall. From 45, it becomes 16.5, and LH from 126 becomes 38. Because as I told you, the peak of action is for about 24 hours. So at this juncture, at this point, when you add one more dose, then the same level can be maintained on the day of oocyte retrieval also. So this is something which I've been using it almost for a year or more, and I find a very good yield of mature oocytes. So what I usually do is the same thing. I give a triptorelin 0.2, and then the next day after 12 hours I repeat 0.1 of the same drug. Now, does the timing differ from HCG? So these are studies which say the timing of the oocyte pickup after GnRH agonist administration has been reported to be almost the same as after HCG triggering. But here again, I would like to share my personal experience where, in comparison to HCG trigger, I find more patients who have been given an agonist trigger having a premature LH surge, and I've seen spontaneous rupture of follicles before OPU. So I generally take patients who have been given GnRH agonist a little bit earlier than what I do for HCG trigger. Usually I take at 35 hours. So for people with GnRH agonist trigger, I take a 15 minutes or half an hour earlier. If I've seen 10 patients who have had spontaneous rupture, almost 9 of them could have had agonist trigger in comparison to HCG trigger. This is in my experience what I had seen. So what are the situations where you have to give only agonist trigger? It's not even a choice. So that would be the donor cycles where you have no justification for giving a HCG trigger. You are not worried about transfer. You are not worried about luteal phase. All you want is a mature oocyte. So for donor cycles, the dictum is please give only agonist trigger. Similarly, for fertility preservation, GnRH agonist is the golden rule. The advantage is you don't subject the patient to hyperstimulation risk. And the second thing is there is a shortened luteal phase, so the patient can have early periods and she can start her cancer treatment quickly. And again, in a situation where you expect, say, 20 oocytes or more, especially in a PCOS women, please give only agonist trigger. So, for women with donor cycles, situations where fertility preservation is considered, or in women whom you are suspecting hyperstimulation, close your eyes and go only for agonist trigger, both for your peace of mind and for the patient's peace of mind. But there are some situations where you have to think twice before giving agonist trigger, is whenever the patient had been on a GnRH depot injection, especially women with endometriosis, where the previous cycle you could have given a leuprolide depot, and then the next cycle you're starting your stimulation and an antac protocol. So this and OC pills the previous cycle, I have seen instances where we land up with the empty follicle syndrome, probably because the HPO axis is downregulated and your agonist trigger has to work on the HPO axis. So these are situations where you can land up with empty follicle syndrome. So if this is the case, you have two choices. One, you give 1 month of drug-free interval and then start your stimulation, or you might have to add HCG. The second thing where your agonist trigger won't work is that agonist protocol, what I have told you already. And as I told earlier, if a woman lands up with the empty follicle syndrome, with a history of GnRH depot or OC pills in the previous cycle, then it's better that you give a HCG and then do the oocyte retrieval. Now, world is trying all permutations, combinations. So, what about combining both HCG and agonist trigger? See, the basic idea is to use the plus of both. So the plus of an agonist trigger is better oocyte quality, better oocyte maturity. The advantage of HCG is you get a better luteal support. So what are the situations where you can consider dual trigger is when the woman is a low responder and you want to consider transfer. So you give an agonist trigger to have a better quality of oocytes, plus you give a HCG to take care of the luteal phase when you want to transfer. So dual trigger improves oocyte maturation while providing more sustained support for the corpus luteum by the HCG what you add. And when you give a dual trigger, you can give a lesser dose of HCG, which is more applicable in women with risk factors for when they are borderline. If it is a concrete case of OHSS, there is no dilemma. So this is again an evolving concept. We'll have to wait and see the advantages of this dual trigger. But remember, it can't be applied for everyone. It has got its own selected indications like low responders. So what the future is going to be, what are the prospects that we have with us for triggering? One is a kisspectin. There are a lot of studies going on in the last decade. Use of kisspectin for final follicular maturation. This molecule actually signals directly to the GnRH neurons through actions on the kisspectin receptor to release GnRH into the portal circulation, which in turn stimulates the secretion of both LH and FSH from the gonadotropes of the anterior pituitary. So the main advantage of kisspectins would be it is more physiological and it can be given either as IV or in the subcutaneous injection. So the main negative factor why this has not gained much popularity is because it's very expensive. So what are the things that's going to be the in thing in the future would be antac protocols, agonist trigger, and if you want to transfer LH activity based luteal support instead of the routine progesterones, and OHSS free clinics and patient friendly luteal phase. These are the things what we are looking at for the future. So, what are the things that's going to fade out? Would be the long agonist protocols where you have no choice of giving a agonist trigger and your hands are tied. So, when you give a long agonist, the only choice is HCG trigger and progesterone based luteal support, and there is a risk of OHSS, painful progesterone injections, and leaky, messy vaginal progesterones. Our patients are waiting for a better alternative. So, to put it in a nutshell, GnRH agonist trigger, I'm sure, is going to rule the world. It's not like it has to be used only for low responders or hyper responders. For every group of patients, agonist trigger has got a role. For hyper responders, you can give an agonist trigger, do it in two compartments, agonist trigger and freeze on and transfer after a month, and you are safe. And for normal responders, you can give an agonist trigger, and if you have a single digit number of oocytes, say less than 10 or 12, and you want to consider a transfer, then you can consider this luteal phase rescue with a very low dose of HCG or giving a higher dose of progesterones. The third group, low responders, also can be benefited with the agonist trigger, and this is a group where you can combine it with HCG to take care of the luteal phase, and you can consider a fresh transfer if the progesterone levels are normal. So to summarize, GnRH agonist trigger, the main plus is because it prevents OHSS and it gives you a better oocyte maturity. But the problem is very poor luteal phase. But again, this can be rescued with various modalities, and we are more physiological when you give an agonist trigger. And probably when I'm talking about all about agonist trigger, I'm sure the future is going to be agonist trigger for all. Thank you for your patient listening.
Yeah, ma'am. Thank you, ma'am. Thank you very much for that wonderful presentation, ma'am. Actually, ma'am, I have been having three questions for you, ma'am. Like one is like whether it can cause OHSS, ma'am. Then you said that it won't cause OHSS, and I was wondering about the quality of this oocyte, ma'am. Mm, when many of the centers are using these antagonist protocols, and you are speaking particularly about this agonist protocols, ma'am, that is something new, ma'am. Okay, ma'am. Thank you for the wonderful session, ma'am. Ma'am, if there is any queries, then I will read it for you, ma'am, in the chat box.
Actually, Mr. Stalin, I'm talking about antagonist protocol only. I'm not talking about agonist protocol, which is a different entity. So,
Okay.
in an antagonist protocol, the trigger, the mature injection, what you give is an agonist. So, this is
Okay. Okay.
agonist protocol, and I'm talking mainly about the drug, what you give for oocyte maturation.
Ma'am, whether the response will be same in all that category of ovarian responders, ma'am. Some people won't respond to all IVF protocols, whatever the drug you give, they may not be responding, ma'am. So in those conditions, whether it will work, ma'am.
Yes. See, nowadays anti protocol is emerging, like you can use it for all type of patients, hyper responders or low responders. So anti protocol, if you use, then there is an option that you can use a agonist trigger, which has its own benefits. Any questions?
Ma'am, I don't find any questions in the chat box, ma'am. I'm just waiting for the
Okay.
participants to post their queries, ma'am. So participants, if you have any queries, you can just post in the chat box so that I can read it for you, madam. Ma'am, there is no questions in the chat box, ma'am. So if there is any queries, then I'll be forwarding through your mail, ma'am.
So I presume that everyone is clear. Good.
Yes, ma'am.
Okay.
Thank you, ma'am. Thank you very much for your time and for the presentation, ma'am. Ma'am, if you allow us, then we can end the webinar for today, ma'am.
Yes. Thank you
Yeah,
very much for the opportunity.
yeah, thank you very much, and thank you, participants, for your patient listening. I'd also like to thank our team for making this webinar possible. Thank you, ma'am.
Thank you, Shield and team.